right, everyone. Welcome to another episode of the Gestalt Education Show. We are expanding on our clinical Savant series today with the one, the only Scott Herbowy. So Scott practices in Austin, Texas. He's spent time with the master himself, Robin McKenzie. You spent a bunch of time over in New Zealand and were able to learn from him himself. And you basically changed the course of Brett and I's clinical practice with, I saw you first in the C course at Logan. And it really, I don't know, it brought MDT together for me like I could not even explain. And so since then, we've been lucky enough to study for our credentialing exam with you, to do all sorts of fun stuff, take a bunch of courses with you. So thank you for that, for leading the way clinically.
Yeah, my pleasure. And, a lot of people say Part C is the course that really brings it together for them. Part A is an introduction, people not sure what's going on. They've got past experiences and they're not sure how quite to fit it, and Part B is like, okay, well, now I got the neck. And so many people say C is really where it started to come together, and I can see what the big picture is on this thing.
Absolutely. Well, let's kind of get, our goal is to talk a little bit clinical. People, you've been on Jason Ward's podcast, you've been on some others and talked about your history, but today let's talk through, like, when did you first kind of start to think about and realize that the extremities were starting to act similarly to the spine, let's say, in the derangement classification?
Well, and I'm dating myself, and I did my diploma with Robin in 1992, and we actually examined extremities then using MDT, and that was 9 years before he wrote the extremity textbook. So he even said in his first book, the extremities, the principles can be equally applied. And I remember having a conversation with him after our 2012 conference where I treated a couple of shoulders on stage, and he sent me an email and he said, "Congratulations, I heard it was great." And I sent back and I said, Robin, your contributions to the spine are obvious, but the extremities might be even bigger. And he sent back and said, yeah, that might be true, but I'm not sure. I never really spent much time on that because I was so focused on the spine. And I'm sure you guys are going to bring it along. So, he had inklings of it, but, the battles he was fighting for so many years, trying to get MDT into almost an acceptable, where people weren't just so anti about it. He fought that battle for so many years. As he said, he didn't have much time to explore that. And now, collectively, so many of the faculty and so many of the practitioners out there have taken this forward. The extremity stuff is really amazing.
It really is.
What do you think, Scott? We asked Mark this question. It was one of the favorite things that we talked about as far as the listeners. MDT is a little bit of a conundrum right now as far as like how to educate, or if we should educate on a pathoanatomical model. Can you comment on the cases that you do that on, when we shouldn't do that, and like what the current contemporary approach would be for the new MDT practitioner as far as perhaps education on a DIS model?
Yeah, this is a very difficult thing because in school we're so educated and geared toward pathoanatomy, and then you get out there and there's so many difficulties with that, and that's how the system, or that's how the medical system is driven. You've got diagnosis A, and then you got your treatment B. And in musculoskeletal medicine, most of the research says that's in question. So I use pathoanatomical education with patients on a very limited basis. There are people that are very into that. I don't typically bring it up if they don't bring it up.
Right.
We use a lot of analogies. People understand a cut knuckle. People understand a broken bone. People don't really understand back pain, because I'm not sure how many people really in the world understand back pain as far as pathoanatomical basis. There's so much debate out there about, is it facet? Is it this and this? Can we figure it out? And it's really so difficult. So I shy away from it in most cases. I think in the extremities there are some things that we can clearly define, but mostly in the spine, I think maybe 10% of the time we can actually really know what's going on in there. And that's hard for clinicians to accept because of our training, our experiences, and the technology that's available to us. So it's hard. It's a balance.
Sure, of course. Derangement, as far as the definition. So the way that we were at least taught originally, one of the components of the definition was that it's a movement obstruction.
Yes.
Now, Richard Rosedale's and others have talked about anecdotal cases where you could have somebody with elbow pain who potentially has zero movement obstruction in their cervical spine, but we can repetitively move their cervical spine and maybe get an abolishment of the symptoms in the elbow. So what is the mechanism? Does that mean that in the derangement classification, maybe there doesn't have to be a movement obstruction? Or do you think that maybe this repetitive movement in the spine might be more neurophysiologic, or we don't know, or what would you say to that?
Well, a couple of things there. First of all, movement loss assessment is very subjective. And if you have somebody that moves exceptionally well, congenitally flexible, as Nick Bogduck would say, they may have a 1% loss of movement that I can't detect.
So it's subtle. I think
it's very subtle,
right.
Especially in the extremities. And, my way of thinking and the way I was trained is derangements have obstruction, although clinically I might not be able to detect that. And but that's only one part of the equation. The symptoms drive everything. So we can get down and say, well, they did or didn't have movement loss. But if you look at the totality of it, derangements have movement loss.
Right.
And I know you mentioned just previously a little bit about disc model. I think the disc model is an excellent thing. And, Robin talked about it forever. And while there's research that supports that model and research that's against that model, I'm not interested in talking about that model with patients, but I think it's an excellent clinical problem solver. It's a way for clinicians to think through mechanics and come to decisions about what to do with patients. And whether it's true or not is actually in some cases irrelevant. It helps you clinically.
Right. So Scott, and you've kind of become renowned, and you're basically the world's expert, I would say, in MDT in the extremities, one of them. So what has made you different than everyone else in the world that might be using MDT principles in the extremities? What are you doing that is basically
Yeah, I'm not sure it's that I've been doing
take the compliment, take it and move
well,
on.
no, but I'm not sure.
Take it.
No, that's fine. And Mark and I, if we go back to the history, and I'm not sure how much you talked to Mark about this, but Robin published a textbook on extremities in 2001, and in preparation for presenting the courses as an organization, he invited a number of us down to New Zealand to spend a week with him seeing patients. I think there were about 20 of us. Mark was one of us, Colin Davies, myself, Kathy Hoyt, people from Europe, and we saw patients. And then the Robin's I don't want to say edict. I'm not sure. Robin's goal was, he said, go out, go back to your countries, teach these courses however you want. You're allowed to, if you want to do a 2-day course or a 3-day course, whatever you want to do, you design the course, and in 2 years we're going to meet back and discuss how it went and actually decide how we're going to present these things.
Right.
So we went away, and Mark and I and Colin taught the first course in Austin, Texas, in extremities. And I look back at that and go, oh boy, were we kind of, none of us wanted to do it solo. We're out there on a wing, and none of us with a parachute, and we're like, let's all three of us do this together. And looking back, I kind of shudder at it. But what we decided was, this is a post-Part D or I'm not sure if it was actually post-credentialing, but certainly prerequisite was Part D. And we said, we don't need to spend a lot of time teaching these people principles. They should have those. And if we go back to how Robin taught courses, my first course with Robin, I don't even think it was called Part A, it was just lumbar spine at the time. Robin came out and talked for about 45 minutes, and then he saw 15 patients on a Part A, which was amazing. And he said, the only way I can demonstrate these these principles is to have patience, and you learn from seeing the patients.
Right.
So Colin and Mark and I made the decision, well, we're not going to teach principles, we're going to see patients. So bring in 8, 10, 12 patients on a day and a half course. And it was spectacular. And, we struggled a bit, and you'd start to learn. But other places in the world went kind of the opposite, with very heavy didactic, a couple of days of lecture and seeing just very limited patients. And I think, being totally honest here, our courses did very well, and the courses where you sat for 2 days and listened to a lot of theory didn't do so well. And at one point, the Mckenzie Institute International wanted to discontinue our extremity courses because they said, well, the attendance is so poor. Well, worldwide, overall, the attendance was poor, but in the United States, our attendance was
Pretty good.
quite good. And we petitioned and eventually got the okay to continue the courses here, where they discontinued them in a lot of the world and didn't add extremities back in until they made the change, adding introduction to extremities in Part C and Part D. But that essentially gave the U.S. about a 6 to 8 year window of additional experience. And it was Mark and I and Colin. And so it's not, I don't think so much that we're so much better, we just have more experience. We saw so many more patients. And, as Robin always said, many times when you were with Robin and something happened clinically and you said, well, why did you do that? And he said, one of two things. I found that's what worked best, or I learned that from a patient. And when you saw those extremity patients over and over, and it was like, oh, I learned. And I can go back to one specific. Dave Oliver and I were in, if I can get the dates maybe straight, I think it was 2003. We were doing a Part A course, and at that time we were trying to promote extremities. So on all my A and B courses, because at that time many people went through A, B, and C and had no concept that MDT could apply to the extremities. So we made the decision, well, in A and B we're going to bring an extremity case. Usually one of the participants, and it was almost always one of the participants from the class, bring them up and show it and give an introduction, so by the time they get to DEED, they didn't have in their mindset that MDT was only the spine. And we brought up this young woman, and her history was 4 years of shoulder pain after a car accident. She said her put her hands up. She saw the crash coming, and the airbag hit her in the forearm, jamming her shoulder posterior. And for 4 years, she said she couldn't elevate her arm past about 120 degrees. And she was told she had an AC sprain. So at that time, we were looking at shoulders, and mainly everything was extension and internal rotation. Extension and internal rotation. So we get this woman up there, and she's got this big limitation in elevation. And we go to look at, or I go to examine extension and internal rotation, expecting to have a big loss of movement. And her extension, she puts her hand up almost near her ear. She touches her internal rotation. She touches C7, and I'm like, oh my gosh, what the heck
What
is
now?
it? What? And I look it over at Dave, and he's got his fingers up, looking at me, and I'm thinking, oh my gosh, what are we going to do with this? She's got no loss of motion. So I said to her finally, I said, so what is the most aggravating thing you can do? And she said, if I teach a patient how to do a press up, that really hurts me. And I'm thinking, well, press up, your arm is sort of, you're doing horizontal abduction all the way into, I guess, neutral, not certainly horizontal adduction, but your full press up, you're in shoulder flexion. Thinking, well, if horizontal abduction bothers you, let's go ahead and horizontally adduct you. So I look at Dave, and Dave goes, kind of shakes his head, yeah, let's do that. So we have her do literally about 6 or 8 horizontal adductions, and she fully extends, she elevates to normal with no pain whatsoever. And now that's become one of the, people say patterns, but that's one of the probably the second most recognized presentations in the shoulders, and that's where it began. And Dave and I still laugh about that. We actually have a video of it, and it's on YouTube, and it's pretty interesting.
Well, it's ironic too, because like for AC joint sprain, this would be the last thing you think that would.
Right,
yeah,
right, because of that compression, and that's how she, you can. It's always debatable how an injury occurs, but you stick your arms up and you get hit by an airbag. You think your arm gets smashed into horizontal adduction.
Well, I think one thing after watching you a bunch, Scott, you seem to never take a shortcut. And I think that's why you're very thorough in your examination. And I think what you end up usually doing is you will uncover that derangement, which a lot of people would classify as an other, simply because you're willing to kind of wait it out and do a really thorough examination. So the original question was, what makes you so good?
Right.
So do you think that is maybe one of the things, like you're willing to keep searching out that combined movement in a derangement that you're going to find that maybe someone else is not going to have the patience to find it?
Yeah, and I don't want to say somebody else can't find it, but it goes back to, Robin. The most common thing Robin used to say in a clinic was, keep this simple. You're making it too difficult. But the second thing, be persistent. Give it heaps. Keep working it. Keep working it. Keep working it. And I think a lot of people, and it's inherent in the presentation where you get such rapid changes so many times that when you don't get that, you start to panic.
Right.
You go, whoa, wait a minute. Yeah, it should have. And then you start jumping all over the place where it's sometimes you have to work it, you have to work it, you have to work it. Recent course I was at, and this is, typical of this presentation, but a lateral shift deformity. In that course on that day, I probably had the guy do 500 side glide and standing before I sent him home. I mean, he was there for an hour and 20 minutes and against the wall, keep going, keep going, keep going, keep going. So a lot of times people aren't persistent enough for either, lack of patience or because, again, things typically change so good, so fast for the better that when it doesn't happen, you start to get a little nervous, like, oh, is this going to happen or not going to happen?
Well, for our listeners out there too, Scott, he taught us, he's like, the curses of MDT are not enough reps, not enough in range, and then going lateral too soon. Mm-hmm. So I think, and that's what, when we've seen you work up patients, whether it's my patients down at Logan or wherever it might be, you seem to give them a ton of reps. Yeah. I think way more reps than anyone else that we've watched. So I think that is also an important thing, because that's going to basically tell you what this potentially would look like in the next 24 to 48 hours, because you're giving them so many reps.
Right, and not only reps while you're with them, but reps while you're away.
Sure.
Or while they're away. The typical classic, do 10 every 2 hours, and where that came from.
That's cute.
yeah, but where that originally came from, it wasn't anything where Robin sat down and figured it out and said, well, this patient did this and this patient did that. He really was like, well, you need to do this frequently. And I said, well, how often? And in New Zealand, like the British Empire or whatever, they would have tea. And they'd have tea in the morning, and they'd have tea at midday, they have tea at lunch, and they had tea in the afternoon, and they had tea at dinner, and they had tea before bed. So Robin was like, we'll do it every time you have tea. Yeah. So that's where that actually came from, the 10 every 2 hours. And there's no magic in that formula. There's no scientific evidence behind it. But the point is they have to do it frequently, and 10 is not a magic number. I mean, I at this point in my my career, I'm like, rarely do I say 10. 15, 20, couple sets of 20. I mean, people need a lot of reps.
Right.
Yeah.
So the other thing is, watching you kind of work through an examination, you are really good, like if we're looking at the elbow, of really doing like a detailed analysis at end range. And I think like people who are assessing joints, whether it's in our field where we're assessing joint play, whatever it might be, they don't get the joint to end range in the assessment. So just watching you in your assessment, you are very good at like the subtleties of end range at whatever joint in the extremity we're talking about.
Right.
Could you speak of maybe the importance of why we need to do that?
Yeah, end range is where all the action occurs.
It's where all the miracles are.
Yeah, I mean, whether it's be in diagnosis or treatment, And end range is almost voodoo for some people. Everybody's afraid of end range, especially if you have somebody as quote unquote hypermobile. Oh my gosh. Oh, and hypermobility is such a myth. I mean, people move differently, and younger people who are flexible, I say that's how they came off the assembly line.
Yeah.
They have that mobility.
Right.
And when you have good mobility, it's very interesting, because when you have great mobility, oh, you're blessed, you're very flexible. And then when you have an injury, it's like, oh, you're hypermobile.
You're screwed.
You're kind of screwed. You're hypermobile. So which is it? Should I be flexible or should I not be flexible? The fact of the matter is, we're all built a bit differently, and you've got to get to end range. And the only way in the extremities to get to end range is to add that pressure.
Sure.
And you have to do it in a way that, if somebody has a limitation and it's obvious and it's painful, you don't push into that. But when somebody moves and it looks like it's full movement and nothing's happening there, you've got to add that pressure to really assess that. And, we talked before about, is end range, as far as determining end range, or obstruction. Sometimes in the extremities, it is subtle. But if you add that pressure, you can find it.
Right.
And that's the key in so many cases.
Yeah. And I think that a lot of times in MDT, it's thought of like, not that it's sloppy, but it's such a global thing. But I remember you telling me a story about, is the anatomist in New Orleans, April?
Charlie April, who passed about 2 months ago. Sad, but I mean, his contributions to medicine and spine is immense. And nice guy. I'm sorry to digress.
No,
on
you
that.
know.
Yeah,
I want you to tell the same story you told me, where
Charlie,
you guys were doing that study, and essentially, I think they got a bunch of rain. You got flooded. I don't know the whole story. But anyways, you guys were basically able to predict the fissures and the herniations. Not that we need to be doing that with the patient, but I think that in the hands of someone who knows what they're doing in their assessment, we can come to the conclusion probably of what that derangement probably looks like, even though we may not be educating off that. I was always fascinated with that.
Well, the study was Robert Metcalf was the main investigator, along with Charlie April. I contributed a few patients. Mark Miller contributed a few patients, and that study was published. And there's a video out there of Charlie at Intradiscal Society meeting, and he stood up there and he said, listen, MDT is a non-invasive discogram. We can figure out these people with their mind and their movements can figure out what I can figure out with literally millions of dollars of equipment.
And that is unbelievable.
Yeah, and it was, it's pretty, but where does that get you? Yeah, you can figure out where the fissure is, but that still doesn't get you to the.
Yeah. But that's a segue. Oh,
go ahead.
That was a segue into something else that you sent me down a path to understanding, because I just always assumed when there was ridiculous symptoms anywhere that was nerve root related. And you talked about Cloward signs. You talked about Cusledge, who is an orthopedic surgeon, and how the intervertebral disc can refer to certain areas like around the shoulder blade without it actually maybe sitting out on the nerve root. This was all news to me. I was never taught that, and that put me on a mission to kind of figure out like what you're talking about. Right. And I think that is very understated, quite honestly.
Yeah, I think it's sad, and I bring it up on most of my courses now, at least the advanced courses, that students aren't being taught Cloward signs.
Right.
And for people listening, just Google Cloward, C-L-O-R, C-L-O-W-A-R-D-S, Cloward signs. Yeah. It's research from 1959, but it is so important for today's world. The disc, the lumbar disc referring without any involvement of the nerve root came from the late 90s when the procedure out there,
I-spine.
IDET.
You told me about it. I looked into it.
It was called intradiscal electrothermal therapy, where they were sticking probes into the disc itself, heating it to 140 degrees Celsius, with the thought of essentially what do we know? Vert Mooney used to stand at conferences and say, I wish as an orthopedic surgeon I had one power, and that was to rapidly degenerate somebody's disc. Because degenerative disc doesn't hurt, it's the degenerating disc that hurts.
Right.
And once it becomes that hunk mass with no annular nuclear complex, it doesn't hurt as much. And so the thought with IDET was, we're going to accelerate that process.
Solder it.
Yeah.
And yeah, basically solder the
fuse
disc,
it. Yeah.
and not solder it in that it's a fusion.
Right.
Solder it in that it doesn't have, because as the disc is degenerating and creates abnormal pressure distribution, that's what's causing the pain. That's what a lot of people think. So, but anyways, in those studies, when they were doing that and sticking those probes in the disc, people were reporting symptoms in their feet. And so that and I think that was Rick Derby in San Francisco that published that, where they said, look at, without even involvement of the nerve root, the disc can hurt all the way down to your feet.
Yeah, that was...
Yeah, and as time goes on, and I'm just going to get a little clinical here, Robin used to say the most important question you ask a patient is constant intermittent. At this point, and I'm not to disagree with my mentor, and certainly, everything I've got is clinically or professionally is because of Robin. To me, symptom location is where it's all about. Symptom location, I can tell if it's, get a good insight. Is it hip or is it lumbar? Is it SI? Is it lumbar? Is it shoulder? Is it neck? Is it thoracic? I mean, symptom location. And, people, a lot of clinicians, well, where do you hurt? And the guy goes, well, I hurt my shoulder, and that's it. That's the end of the questioning. Well, is it achy? I don't care if it's achy. I want to know where it is. Is it anterior? Is it posterior? Is it lateral? Does it go into your scapula? Does it go up into your neck? Does it go down your arm? Look at the Expo study, and I don't know if you've talked about this on
with Mark,
previous things.
Yep.
Yeah, but, do you have numbness or tingling? That's a huge question. And people do not spend, or clinicians, I don't think, I probably minimum 8 or 10 questions on symptom location with any patient, even the most straightforward guy.
Right.
Symptom location, man, that's if I could only do one thing with a patient before I start moving them, I want to know where your symptoms are, have been, can be, and where they are right now.
Yeah, that's interesting. What about the better worse section? That's another thing that we focus on a ton if you go through an MDT course and stuff. I mean, at what point when you're going through those, or are you already developing in your direction, the classification? Like you said, symptom location is number one. What would be number two? Is that better worse, or is it?
Well, I know a lot of people. I mean, symptom behavior, is it better with this, worse with this? Yeah, you can get some good insight on that, but you also have to take it with a grain of salt because it can be paradoxical. How many people say, well, I can't bend backwards and ultimately need extension? Mm-hmm. I feel better if I stretch forward, if I, pull my knees. I mean, we have to remember, and I know it's funny now, being older, Williams flexion exercises dominated.
Oh, God, yeah.
You know what they were.
Oh, yeah.
It's on our PT boards. Yeah, for chiropractic school.
But on a lot of courses now with younger clinicians, and I say Williams flexion exercises, and they look at me with a blank stare, like I'm talking about laughing in the some ancient TV show, and but Williams flexion dominated spine care for years and years and years. And you have to look at it and go, well, wait a minute, the anatomy and the disc or centralization wasn't any different, but why was that so pervasive? And the reason is it's the paradoxical nature of back pain. Yeah, lay down and pull your knees to your chest and you stretch those angry muscles, and under low pressure the disc isn't affected.
Yes.
So you feel really good.
Yeah, right.
I mean, people were pulling their knees to their chest and wagging their knees side to side for 3 or 4 decades, and we didn't have masses of people getting worse. A lot of them reported feeling better. That's why they continued with it. So it's that paradoxical nature that of symptom behavior that's so perplexing for a lot of people.
So pay attention to that section. That gives you a starting point, but don't necessarily be married to it.
Oh,
Don't
you
be
can't
afraid
be
to do
married
that.
to it
Yeah.
at all.
Yeah.
I mean, the classic flexion responder, no different than large obstruction to extension, will tell you the exact opposite. It hurts me to extend, but that's the answer. It hurts me to flex, but that's the answer.
I think too, Scott. I mean, like the more I've gotten to know you, and you know, socially and things like that, we've talked about. I mean, you have been around all the giants in the world as far as manual medicine and rehab. So you've met Yonda, you've met Levitt, you've met Bert Mooney, you've met all Dave Butler, all these people. And you have stayed real pure to
Butler,
MDT.
Mulligan, I'll bring in
Yeah,
a few others.
Yeah, I mean, it's quite amazing.
I spent time in New Zealand after I finished my diploma. I spent a few days with Mulligan in his clinic, running around with my video camera, which in 1992 was the size of a half a suitcase.
Yeah.
And I still have those VCRs buried somewhere deep in his
my
clinic,
God.
which is crazy.
Yeah.
But
So Brian Mulligan, he's got his own assessment and treatment.
Yeah.
So and I'm sure you were enamored with some of the things that Brian Mulligan was doing. What has kept you so pure in MDT as you've been exposed to all these other amazing things that you could be doing?
it's the assessment.
Right.
I mean, Brian is an amazing man, and he's certainly engaging, and he has some excellent things for this and this and this, and not as a criticism, but Brian didn't have the evaluation,
Sure.
the assessment process, and that's what a lot of people don't get about MDT. MDT is not about initially treatment; it's about that assessment.
No one understands that quite like they should.
A lot
It's
of people
so,
don't.
I mean,
And even the people, Mark and I taught the diploma for a number of years together, and then I went on and taught it beyond him when he moved on to Florida and his things. But so commonly we would have to say, one of the residents, your problem is you're trying to fix this guy and you don't understand him. And if you don't understand him, you've talked to Colin Davies. Colin Davies will tell you over and over, they don't understand. It's an assessment system. I'm not trying to fix this guy. I'm trying to assess him. And once I assess him and figure out what he has, then I have a chance of fixing him. And, again, nothing against Brian. Brian had all these amazing techniques. I mean, I don't know if you ever saw his original little book, Snags, Nags.
Yeah, of course.
Yeah, the little white book in there. But there was nothing about assessment there. It was a compendium of techniques, and the techniques are beautiful, and I use some of them. I use them in the framework of MDT, but that's, I think, the thing that set for me apart. Robin with the assessment process versus other approaches I saw that were. I spent 7 days in it might have been 9 days with Stanley Paris, who you might know.
Great manipulator.
Yeah, back in the day when their S1 was 9 days long, which was like, oh my God, can you imagine spending 8 hours for 9 days
That's how you
straight?
get divorced.
Oh
Right?
my God!
That is how you get
Oh
divorced.
my gosh! And by day 5, you were just like, oh, whatever. But it was just so many, this technique, and there wasn't a lot about, when do I use it? How do I get there?
Sure.
I think that for me was the big difference.
Right.
Yeah, that's great. I love it.
Just, so tell us, besides the clinical expertise of Robin McKenzie, what are the things that you learned? What made him so special in so many different ways that maybe our listeners, may not have heard?
Obviously clinically he was a giant, but also incredibly humble man. He changed the world.
For a guru, that's kind of hard.
He changed the world. He changed physical therapy. He changed the world, and I think going forward, musculoskeletal medicine, ultimately he'll be recognized as one of the most influential people
Mount
ever.
Rushmore. His face will be on it.
He is a Mount Rushmore guy, but he was so humble about it.
So
he was never boastful. What a nice man.
Right.
I mean, just a nice person very genuine. I'll tell you the story. I don't know if Mark told you any stories about when we went down to New Zealand.
He told us a bunch, but
Yeah.
tell again.
So I think it was, I don't know, it was 2003, 2001, we had to go down for a conference, and we emailed Robin and said, hey, would you like to play golf with us? And he sent back and said, well, I'm not sure. I'm a bit busy and everything. And so Mark and I, long flight, and we get down there, and we're staying at a little motel, literally one story, that type of thing, motel, next to the golf course. And we're going to go out and play golf. And we get there, and we get in and get a shower. We're on the flight forever, and all of a sudden there's a knock at the door, and open the door, and there's Robin standing there, and he's got on, as Robin sometimes did with his fashion, I think it was a orange plaid shorts and a green plaid top, with kind of a Gilligan hat, if people can relate to that, with silver oxide all over his face. He was almost unrecognizable, and he said, well, I've heard you guys need a fourth. Are we going to go out for this? So we went out, we played golf, and it was wonderful. And then he said, so what are you guys doing tonight? Well, I don't know. Well, come on over. Joy would like to see you. So we go over to his house, and Joy, his wife, is there, and Bert from Holland, who was the fourth, and we sit down, and Robin pulls out some wine, and we're drinking everything, and Joy says, so what are we having for dinner tonight, or tea? What are we having for tea? And Max says, well, I'm not sure, and she's like, go get some fish and chips. So she sends him on an errand to go get fish and chips. And then Mark and I and Bert are standing there in his kitchen drinking. And Mark's looking at me, and he's like, this is like being, can you believe this? We got Robin McKenzie going out and getting us dinner tonight.
Hurry up. Yeah, I'm hungry.
Yeah. So Robin comes back, and it's wrapped in newspaper, traditional. And, it's amazing.
Yeah.
I mean, can you imagine you're with, I don't know, president, or you're with some dignitary, and he's going to run out and get you takeout food.
Right.
And Robin thought nothing of it. It was just like, yeah, I got the boys over. We're going to have food, and I got to go
amazing.
get it.
Yeah.
Just absolutely amazing. Just a genuine guy, not pretentious, and for all the things he did, incredibly humble. It's hard, it's hard for me to put it all in words.
As the system moves forward, MDT has embraced certain things, for example, contractile dysfunction. So they have embraced the new tendon theories of Kahn and Jill Cook and things like that.
Yeah.
So moving forward, does MDT, does it morph and change more as time goes on, or do you feel like it would be better just to kind of stick with the original principles, or what's your, maybe if I said it a different way, what does Mckenzie look like in 50 years? How does it evolve?
Well, wait a minute. I don't think our principles change. Our knowledge and how we might approach things change based on the evidence.
Sure.
Robin wrote, again, the Extremity textbook in 2001, and he talked about contractile dysfunction based on his experience, and how we approach that now has changed based on the evidence. So that's okay. But, I think Robin, if I can get this right, he said, how we approach patients, the explanation may change in 100 years, but how we approach them won't. And, so...
That's how you know you have good principles, right?
Yeah, our principles are sound. And again, contractile dysfunction, again, as Robin talked about in the original book, it wasn't at that time much research backing up, but it was his experiences, and it's amazing how his experiences have now become validated with the evidence. And I'll bring up another example. I have a copy of Robin's instructions to patients. I'm not sure if it was the 60s or 70s about, okay, you go away, you should extend a couple times a day, you should sit better, et cetera, et cetera. And then that was again, somewhere let's say 1970, give or take a few years. And then in 2004, Larson publishes in Spine and says, if you extend twice a day and sit better, you have a 43% reduction in recurrent back pain.
Isn't that crazy? No one talks about that paper. Like, to me, that is just...
Oh, it's amazing.
I mean, if you knew that, it would motivate you to twice a day doing 10
right,
I mean, it's just the best preventative medicine that's ever existed, basically.
Right. And you know, so something Robin was doing, so that's whatever, I think 2004, give or take, with Larson's patient, that's what Robin was doing 30 or 40 years earlier, and it's been validated. So that's an amazing thing. That's an amazing thing.
Yeah.
So
principles stay true. And
yeah,
that's
they
cool
do
MDT.
train. Yeah, they do. They absolutely do. And I'm firmly of the belief that, you know, these principles will carry through.
Yeah, it's beautiful. Awesome. Well, Scott, thank you for sitting down with us, man. That was insightful, and I know we Brett and I are so appreciative of your work and you carrying it on and exposing it to chiropractors. I think that's been one thing that's been
I'm so
amazing.
happy with that. You know, Robin, you know, all this turf battle, chiropractors, therapists, you know, Robin said, you know, way back when, he said, look at, I'll train a plumber. There are so many people out there that need help. And if you look at the statistics out there, the prevalence rates, musculoskeletal problems in the general population are so pervasive. These people need help.
Right.
So, you know, whether you be a chiropractor or an osteopath or a physical therapist or a plumber, if you can help people, Robin would be all for it. He was so patient focused.
Mm-hmm. Yeah.
I think for our listeners out there too, just to like understand all the miracles that you would potentially be getting with press-ups in a low back or retractions in a cervical spine, all of that is possible in the extremity joints if you're willing. Like, the same mind-blowing results in those examples are possible in our extremity complaints if you're willing to do a good assessment.
I'm going to take it a bit further. They're possible quicker.
Oh,
I have never seen a derangement in the cervical spine reduced with 3 repetitions of retraction. I see shoulder derangements reduced with 3 repetitions.
Yeah.
right.
Yeah.
Which is absolutely amazing.
Or like in the wrist, Mark Miller said something. He goes, I can't remember the last wrist complaint that I saw that wasn't a derangement, is what his exact words. So I mean, like, there's so much low-hanging fruit out there. And I think, like, if you're listening, people are like, yeah, sure. But, like, until you actually, like, see it, you know, and I mean, that gets exposed in the MDT courses as far as the extremity courses. But, I mean, it will literally blow your mind, just like a press-up would blow your mind or retraction.
And I think that goes back to what I said about, you know, Robin's original courses. He said, the only way I can teach these things and demonstrate it is to see patients. And, you know, I talk about in courses, the course I just mentioned in South America, I mentioned privately to you, saw such an incredible variety of patients. And I say to the people all the time, I could talk about this all day, but until you see it, you can't appreciate it.
Right.
And, you know, I can actually look back. I think I did my original course with Robin in 1984. I still remember some of those patients that he saw. There was a lateral shift that he saw in that course. And I was like, and then I go back to my clinic, and on Monday morning, my first patient is a lateral shift. And I'm thinking, oh my gosh, last week I would have put a hop back on him and prayed, but he didn't come back. And now...
And called it QL spasm.
Yeah. And I actually went in the room and I said to the guy, I have a book about this. Do you mind if I bring it in? And he said, no, bring the book in. And so we're standing there, and I'm flipping through the pages, and I'm on the shift correction, and he's like, no, you need to put your foot over here, because he's looking at the pages in the book. I mean, those experiences are, I mean,
what a story that is.
I love that.
That's another one. Yeah.
Well, I forgot to mention that we're drinking an awesome Pina Napa from the Rutherford region, so it's great. And with that being said, guys, thank you.
I hate to be this too long. I'm sorry.
No,
you were so good. It was
all right. Absolutely perfect. So we're going to go have a really good dinner.
Have a good night.
And probably have more discussions off air. So anyway, I'm sure that we'll have more discussions in the future with you, Scott.
I appreciate it.
You can't get rid of us this quick.
I appreciate you guys. Thank you so much.
Scott.
All right. Thank you. And keep listening to your patients, guys. They have all the answers, right? So keep
The
it up.
the patients will tell you.
Absolutely. All right. Have a good one, guys.